3, 2, 1. Hey guys, welcome back to the Foam Frat podcast. Tyler and Sam here. We have a really fun episode. We interviewed Dr. Steve Smith from Dr. Steve Smith's ECG blog, or Dr. Smith's ECG blog. And this was one I got to cross off my bucket list. I've always wanted to have him on the podcast. I followed his blog religiously throughout paramedic school. He's been doing that since 2008. Did you know that? 2008 is when he started the blog, November of 2008. And he's kept it going, and he's contributed a ton to Foam Ed. And it was fun just to sit down and pick his brain on some stuff. And so Tom Bouthillet, who has been one of the newest contributors to Foam Frat, he was able to arrange the interview, and we were able to steal like 20 minutes from Dr. Smith's time to address a question that I had. And what do you think about that question I had, Sam?
It's a valid question. So, yeah, I think that I can't really add too much. And I guess before we really start getting into it, I'll just preface this with, when Tyler sent me the interview, it's about 20-ish, a little bit over 20 minutes long. And I was just, before the podcast, I was just getting done telling Tyler that I listened to that podcast like 5 or 6 times because there's a lot of information. Like Dr. Smith hit on some points, and I had to really wrap my head around why he went there with those points and appreciate what he said about kind of the statistics of doing different views as far as either posteriors or moving a V4R. So if I really felt like I was reading one of his blogs, because if you ever want to feel like an idiot about ECGs, like any time of day, just go look up his blog and read the entire thing from start to finish without skipping a word. And he'd be like, all right, clearly I have to read some more of these. And I think pretty much everybody feels like that when they look at his blogs. But I kind of felt that way with some of his answers, where I had to rewind that and be like, wait a second, what did he say exactly? And why did he bring up that point first? But it's the points are super valid, and they're very interesting, and they really make you think. But before we get into the podcast, so let's go back to what you just said. What do I think about that question? It's a valid question, because the initial thing that you posted on Facebook, which was very entertaining, God, so entertaining to watch, was it was something along the lines of like, I don't feel like I get that much more information or anything useful or something along those lines from essentially placing V4R. Because if you have ST elevation in your inferior leads, so 2-3 AVF already, I'm already going to a cath lab, and I'm already kind of evaluating the blood pressure. So I already have my regular 12 lead. I already have my blood pressure. What additional information is moving V4 over to the opposite side and running that V4R going to give me? Is that going to affect whether I give nitro or not? Is this a pivotal, piece of information that's going to change the case, where I'm now going to report this to the cath lab and they are going to, change something that they do? Or is there such a thing as an isolated RV infarction, where I saw nothing on my initial ECG, and then I ran this V4R, and there was the money maker right there. And I don't want to speculate on any of it right now, because I can't say anything better than Dr. Smith did, and he's certainly the authority on this stuff. But excellent questions, definitely worth asking, and the answers, you got to chew on them a little bit. But I thought you did a great job facilitating the conversation, and it's a super good interview.
Awesome, man. Well, let's not spoil it anymore, and let's get right to the interview. And we talk about in the interview his book at the very end. He's got a book called ECG and the Acute MI. We're going to put a link to that in the show notes, so make sure you check it out. All right, let's roll it. If I get a 12-lead ECG and I see that I have ST elevation in 2-3 and AVF, patient fits the story, they're having chest pressure or whatever, is it necessary for me to throw V4R on at that point? And the typical response is, well, to see maybe if you should give nitro or not. But when I've reviewed these cases, I haven't found anybody whose blood pressure wouldn't have excluded them from receiving nitro, despite me looking at V4R. And so that's the first question I want to pose is, if I see I got an inferior wall MI, I'm already going to the cath lab. Is it necessary for me to do V4R?
Well, I would say for sure it's not worth it to delay transport to get it. But if you can somehow do it without delay, I don't know, if you do it on the run, I suppose you don't get a good EKG if you're rolling in the ambulance, or do you?
Yeah, we do. Well, in the hell, yeah, we still do. That's, yeah.
Then I'd say it's worthwhile doing for this reason. First of all, if you have ST elevation in lead V1, that's very specific already for a right ventricular MI, and only 0.5 millimeters is pretty specific. So if you see that, you've already made the diagnosis and don't need it anymore. However, if there's any ST depression in lead V2, it competes with the ST elevation in lead V1. And first of all, ST elevation in lead V1 is not all that sensitive, but it's especially insensitive if there's any ST depression in lead V2. So in that case, you're not going to be able to rely on V1. Do you need to get it all? First of all, why are we giving nitroglycerin sublingual? Why is that an issue? And no one's ever shown that it's of any use. IV nitroglycerin was shown to be beneficial back in the pre-reperfusion era when they didn't have anything else to give. We have no idea if sublingual nitroglycerin has any benefit whatsoever for ST elevation MI, or occlusion MI is what I prefer to call it. If you're doing it just to decide whether to give nitroglycerin or not, I just say just go. What is the benefit then of diagnosing a right ventricular MI? This is the one thing I've seen where it could be beneficial. You're going to the cath lab anyway, and they're going to look at the arteries. But does looking at the arteries tell you everything you need to know? No, it doesn't. You can have a culprit in the proximal RCA that then thromboses and embolizes to the mid-RCA. So when the angiographer goes in with the inferior MI, they look and they see, oh, it's occluded in the mid-RCA, and they don't see that the actual culprit is in the proximal RCA. Yes, they open up the artery, but then they don't put the stent in at the spot where the ulcerated plaque is, which is going to cause trouble in the future if they don't protect that. That's a rare situation, but it is a useful situation. The only time I've ever seen it, the diagnosis was made by lead V1, not by V4R. So I'd say it's not really worthwhile. It's not worthwhile to delay anything to get V4R, and it's not worthwhile. Certainly, I wouldn't spend a lot of time deciding whether you're going to give nitroglycerin or not. Just don't give it if you're worried, because there's no evidence it works.
Have you seen any cases where a patient's blood pressure was completely fine, and I should say even maybe elevated, they gave nitro, and because it was an RV infarct and they didn't detect it, it just plummeted the blood pressure?
I've seen cases where the blood pressure plummeted, yes, but I haven't seen any cases where I think it made a difference. You just nitroglycerin has a half-life of 3 minutes. It goes away. You give some IV fluids, the blood pressure comes right back up. So did the patient have an adverse outcome because they had a transitory hypotension? No.
So I guess my thoughts are, first, I do agree that it should not significantly delay transport, although we should be mindful here that there are so many things we do in EMS that don't change treatment in the field, and yet we still do them. I mean, when you think of the millions of times that an EMT or paramedic has checked to see if pupils were equal in round and reactive to light, and how often that changed field treatment for, blunt force trauma to the head, there's so many things we do that do not change field treatment. And if it does field treatment, we don't even know if it's a positive change to field treatment. Let's say, well, now I'm going to hyperventilate because they might be herniating. Were they really herniating? Was the hyperventilation good? So did you make a positive change in your field treatment based on that? The three of us having this conversation are enthusiasts when it comes to medical education and electrocardiography. And so I personally might elect to do a right-sided EKG or even modified posterior chest leads on a specific case, just think for my own academic curiosity to see if it is a right ventricular infarction, to see if the posterior leads pick up ST elevation. But I think it's one of those things you have to know the limitations of those tests. And do I think it's more instructive than a physical exam, the heart rate and the blood pressure? No, I don't. But yeah, I would probably do it. I would probably do it, but not blindly. I would not significantly delay transport, but I might in fact do it. So I think it's kind of nuanced, because if you're gearing your whole system to your top 0.5% of paramedics in the field who are such expert electrocardiographers and have such nuanced understanding of the total presentation, you might say, well, no, those people don't need to do any modified chest leads. But what about the folks right in the middle of the bell curve? Do they all have the discretion to decide, yeah, our protocol says we give sublingual nitro, but I don't, because I don't think that it, has been shown to reduce mortality. It is still the delegated practice of medicine. So if you're expected to give nitroglycerin and the heart rate is, maybe 60, it's not quite bradycardic, but it's close. And the blood pressure, systolic pressure is above 100, but not significantly above 100. It seems to me that if you do right-sided ECG and V4R is negative, then you're in a better place to give the nitroglycerin. And if the patient does have, bottom out their pressure, you're like, hey, well, I checked the right-sided chest leads. Yeah. There was no elevation, so I proceeded with the protocol. The pressure dropped. I withheld it from that point, gave a fluid bolus. So somewhere in there, it seems like it could be part of the responsible pre-hospital practice of medicine.
I agree with Tom that I like to do it. It's fun, and it's also something that you may have to do in order to completely comply with your protocols. But my point is, I'm not sure those protocols are even worthwhile.
Absolutely. Let's talk about the isolated RV infarct. How often is a traditional 12 lead completely normal, and then you do a right-sided ECG and you have ST elevation, or a posterior and have elevation? Have you seen that often?
I have seen one isolated right ventricular MI in my 34 years, and that one had clear ST elevation in lead V1. It also had deep Q waves in the inferior leads, because there was an old completed inferior wall MI. So it was a proximal right coronary artery occlusion that did not manifest as ST elevation in the inferior leads because the inferior wall was already completely dead. It only manifested as ST elevation in lead V1. So this is just sort of a fun case, because you're not going to see this often at all.
So Tyler also mentioned isolated posterior STEMI, and I think that's a different question, isn't it? Because I know, Steve, one of your major contributions to that conversation is that posterior chest leads are insensitive. And so if we have ST depression that's maximal in the right precordial leads over the left precordial leads, we can't rule out acute posterior STEMI if we don't have ST elevation in leads V8, V9. Could you talk to that point?
Yeah. In fact, we have an article under consideration at the Journal of the American Heart Association right now, where we looked at, I read the ECGs, all the ECGs on 808 patients, and a large percentage of them had, I decided, do they have occlusion myocardial infarction or not? I read the first EKG. If it didn't, I'd go to the second EKG, and I couldn't change my mind on the first once I got to the second. And my sensitivity for occlusion MI overall was about 90%, and was also, if the patient had any ST depression, as in V2 in V1 to V4, any ST depression in V1 to V4, the sensitivity for posterior OMI was extremely high, and the specificity was extremely high. And we didn't do posterior leads on those patients, but I don't think you need them. The reason that people think you need them is they've always depended on having at least 1 millimeter or 2 millimeters of ST depression in V1 to V4 in order to make the diagnosis. Well, think about the normal EKG. It almost always has some ST elevation in V1 to V4. So if you have any ST depression in those leads, it's in the setting of someone who's got acute chest pain, it is likely to be a posterior OMI. So I'm of the opinion that you can make the diagnosis without posterior leads. I have no objection to doing posterior leads. I think, except that they can lead you astray. If they're negative, you say, oh, see, it wasn't a posterior MI, but it was. Here's one situation where it can be of benefit. This is getting complicated. Most subendocardial ischemia has its maximal ST depression in V5 and V6, which differentiates it from posterior MI, which is V1 to V4. And this is another thing we showed in this study we hope to publish. So ST depression V5 and V6 is diffuse subendocardial ischemia. And we have diffuse subendocardial ischemia. The overlying leads everywhere show ST depression. So there is one study that I'm aware of that showed that in patients with subendocardial ischemia, posterior leads also show ST depression rather than showing ST elevation. So it might help in that situation if you're wondering if someone's actually got a posterior MI or if they've got subendocardial ischemia. ST depression in posterior leads could help you make that decision.
So I've got one follow-up question for you there, Steve, because I've noticed a lot of times in a patient with either pre-existing stable coronary artery disease that maybe presents with AFib and rapid ventricular response and has a heart rate, of 130 and has ST depression. Sometimes I'm like, where is it maximal? It's so close between the right and the left precordial leads. Is that a similar situation, or would you want the heart rate to be slowed down first?
You always get the heart rate slowed down first before you decide whether it's subendocardial ischemia or posterior MI. People with exactly the situation you're talking about, AFib with RVR, when they don't have posterior MI, they frequently have maximal ST depression V1 to V4. I don't know why that is, but that's just my experience. I always cardiovert them and then wait 15 minutes and repeat the ECG and see if there's still ST depression and where it is.
Interesting. And then how about bedside echo?
Bedside echo with subendocardial ischemia, bedside echo can be completely normal because the epicardium is still functioning fine. But with posterior MI, if you're really good at it, you can see sometimes a posterior lateral wall motion abnormality. But I would not, it's not, bedside echoes don't use contrast. We don't use Definity bubble contrast. And not everyone's an expert at reading them, just like not everyone's an expert at reading EKG either. So if you're really good at cardiac echo, then that's very useful for you.
I was reading your paper, Dr. Smith, where you looked at ST depression in lead 1, and then you also evaluated V1 as well. Can you talk about some of the findings that you had with that? Because there's a lot of rules I've heard, like ST elevation in lead 3 greater than 2, ST depression in lead 1 for looking for RV involvement. What did you guys find in that paper?
It did not work out. If ST depression in lead 1 in inferior MI does help you decide whether it's a right coronary artery. And in that sense, it does help you decide that it could be a right ventricular MI, because right ventricular MIs only happen with right coronary artery occlusions. But once you know it's a right coronary artery occlusion, the presence or absence of ST depression in lead 1 does not help you in determining whether it's an RV infarct or not, according to our data. Lead V1, as I was saying before, we looked at that. That was much better than lead 1. But as I said before, if you have ST depression in lead V2, in other words, a concurrent posterior MI, then that will obliterate the ST elevation in lead V1, and the sensitivity of V1 then goes way down. This was also shown by Kosuge from Japan. He looked in lead V4R. Patients who had a posterior MI had very poor, V4R was very poorly sensitive for a right ventricular MI in patients with a posterior MI, because it pulls down, they're opposite leads. It pulls down that ST elevation V4R and gives you a false negative.
Dr. Smith, do you have any sense that, in some places they'll just do a complete right-sided ECG? I don't know if that is ever your practice at Hennepin.
I do that in the ED quite often.
So
if I'm waiting for the angiographer team to come, I don't delay that but out of my curiosity, I'll do it.
have you ever flipped V1 and V2, or just leave those two in place and then just put V3?
I always flip V1 and V2. It's just not
just do a perfectly right-sided start to finish. Gotcha. Yeah. Is there a heart rate below which you would withhold nitroglycerin? Let's say the pressure's fine, like abundantly fine, but the patient's in heart block, something like that. Is there a heart rate you won't go below?
If they have like third degree heart block or second degree Mobitz 2 or third degree heart block, I would not want to give nitroglycerin, because then you don't have if there is vasodilation, you don't have the compensatory capability of increasing the heart rate to bring blood pressure back up. And atropine won't work either. So if it's just sinus bradycardia, though, you can always give atropine.
True. Yeah, I just have, obviously, a lot of paramedics out there, they see various heart blocks, especially with acute inferior, well, with any MI. Sure. Maybe with wide complex escape rhythm, if it's anterior, we're talking about inferior. Yeah. So even if it's a narrow complex escape rhythm, if you're in third degree block with acute inferior STEMI, you would just say stand pat.
Yeah.
In that same vein, I with nitro, which I don't know, it doesn't sound like you're a big fan of nitro, and I totally agree with the reasoning, and it hasn't really shown to improve outcomes, but it is something that's in our guideline. And it's interesting because a lot of the guidelines use a systolic blood pressure as the cutoff for whether you're going to give nitro or not, whether that be 100 or 120, some say 90. And I always thought that was interesting because like your diastolic is really what's perfusing your coronary arteries, right? And so like if I have a blood pressure of 120, but let's say it's 120 over 50 or 60, like especially in the presence of an MI, if I'm thinking that I have an elevated left ventricular end diastolic pressure, like who knows, I may need more of a diastolic pressure to even perfuse those coronary arteries. So do you think it makes sense, if you're looking at it, to not only just look at that systolic, but look at that diastolic? And do you have a diastolic where you're like, it doesn't make sense to give nitro right?
If the diastolic is low, like below 70, I wouldn't give it for sure. Also, remember, we're talking about, and you're exactly right, diastolic blood pressure is what matters. Usually there's some correlation, though, between systolic and diastolic blood pressure, unless there's problems with aortic insufficiency or very low systemic vascular resistance or something like that, then they're generally fairly well correlated. Again, I'm not a big fan of nitroglycerin anyway, so I would never insist that someone give it for anything in STEMI. We did a study here at Hennepin, which you'll find interesting, which you may not know about because it was only published in abstract form at the pre-hospital conference in 2008. And that's where we did an ECG on patients in the field, and we did not give them nitro before the ECG, only afterwards. And there were 87 patients who had a STEMI, and they got nitro after getting their first EKG. By the time of arrival, only 3 patients had resolution of their ST elevation on the ECG. So that's about what you would expect from spontaneous reperfusion, or in fact, you'd probably even expect more. So that's evidence that nitroglycerin has no effect on STEMI.
Dr. Smith, I appreciate you taking the time to talk with us, and we appreciate everything you do for the FOAMed community and putting out content on a regular basis. You have your ECG book that's available. Is that on your website that's available?
It is. It's a link right underneath the picture of the book. There's a link to a free PDF of it, which is pirated because the publisher never would get back to me about publishing it again. And so some enterprising individual made that PDF and was selling it on eBay for $50. So I bought a copy of it myself. And
wow.
now I put it on my website for free. So it's illegal, but it's the way it is.
Awesome. Well, thank you so much, Tom. Thanks for coordinating us to be able to talk, and
Oh, you bet.
appreciate it.
Thank you guys for all the great work you do.